Thank you very much, Steve. It's my pleasure to be with you today. I'm very excited to share my research and interest in working with individuals with cognitive and physical disabilities and related conditions. The research stems from my time working there in the Reno, Carson, and also Fallon, and out in Elko and Ely in Reno, Nevada area. During my doctoral program, I spent 5.5 years working for the Rural Regional Center there, and was just interested in the processes that the folks were facing just day to day. So did a couple of small little studies that I'm interested to share. So I'll get right into it. So my doctoral dissertation was on acceptance and commitment therapy with dually diagnosed individuals. I became interested in the cognitively and physically impaired, like I said, when I was going through the doctoral program, and also individuals with related conditions such as Asperger's and autism. So my work today will also discuss that, and I'd be interested in any questions and discussion around that. There was a small limited group of folks I did see who have limitations that look like topographically mental retardation, but come from TBI or traumatic brain injury from car accidents, etc. So all the data that I present for my dissertation it comes from individuals who were within that full spectrum. So my title today is, of course, ACT with dually diagnosed individuals. And by dually diagnosed, I understand that there is a literature base that calls dual diagnosis in terms of substance abuse, but in our case, we're meaning today dually diagnosed with either mental retardation, borderline intellectual functioning, or a related condition, and a mental health or behavioral health issue. So let's get started. So developmentally disabled individuals presenting with psychopathology present a real challenge to service providers. The prevalence rates for Axis I disorders are in general slightly higher than our general population. The developmentally disabled, hereafter I'm just going to call them DD or double DD population, has been served primarily through pharmacology or behavioral modification rather than traditional psychotherapy. When intervention has been attempted, it's been through structural behavioral manipulation, and a lot of it seeks to change, modify, eliminate, or control symptoms. So at the core, we're looking at this tension with disability and mental health. Diagnosing is a real challenge. Service providers presented with an individual with verbal limitations and or intellectual challenges and or physical challenges are not often sure what they're looking at. Is it mental illness due to the physical limitations? Is it due to the cognitive or intellectual limitations? Is it due to the verbal repertoire, the inability to express themselves? So I think that the first challenge that anyone in this field is presented with is just understanding what you're looking at when an individual presents for services. So it's hard to parse features. There's also external contingencies at work, and I'll talk about that at some length today. And I wrote just financial, for example, but there's a lot of external contingencies, especially in the state of Nevada, as many of you in the room, I'm sure, who have worked for either Rural Regional or a Sierra Regional Center know. Some of these folks are at risk of losing their services based on a diagnosis. Some of them present with an IQ of 70 and adaptive skills that would maintain them higher than a diagnosis of mental retardation, and so then it becomes an argument whether they should be served through the pot of money for mental retardation set aside by the state, or for the pot of money set aside for mental illness. And I know from various conversations on a state level, there's always an argument about who's going to help these individuals. And I saw it way too many times, folks falling through the cracks. And so there's these external contingencies in terms of who's going to pay and when and how. Back on a more individual, on a micro level again, you're seldom dealing with one disability. You're looking with folks who have multiple issues. They may have cerebral palsy and have a physical limitation, but then be cognitively normal, yet because of the physical limitation, not be subject to the same types of social interactions that the cognitively normal person would, and so not have as many opportunities to practice social skills, so therefore be socially handicapped. So in general, when you're dealing with this population, it's kind of a moving target, and you're seldom dealing with just one disability. There is a low base rate in terms of referral for one-on-one therapy. This is not something that someone sitting in their office in a traditional psychotherapy setting is going to see that often. However, the opposite is there's a high base rate for patient referrals in terms of like inpatient settings. Also, for our hospitals, in particular in Reno, I remember the statistics when I was there 4 years ago. I spoke to some folks over at Renown, and they mentioned that somewhere between, I don't know, I think she said 60 to 70% of individuals coming to the emergency room at Renown were, in her opinion, not only underinsured or non-insured, therefore causing an economic burden on the state, but also suffering from some learning disability and or cognitive limitation and or physical limitation that she felt that might have been served better elsewhere in a more proactive way, because it seems as though these are individuals who end up getting served in a crisis. For example, we would have one of my clients really liked to see the handsome firemen show up, and so she would call 911, and the handsome firemen paramedics would show up over and over, and she enjoyed that trip to the hospital, and she enjoyed the quote hot firemen. And so, you know, I see you guys smiling. It's you know, this was something that was creating a burden for the emergency room. She enjoyed it very much, but it was creating an economic burden, as well as the questions to me and our case team, our case management team. How do you intervene on this behavior? So these are some of the core issues I'll be discussing today. So what we're looking at in terms of the way I look at it, population characteristics really can be kind of boiled down in this way. We've got this spectrum of mental illness, whereby I believe that I've pretty much seen the same spectrum as the cognitively normal in this population. I've pretty much seen, you know, you name it, phobias, substance abuse, etc. So I do pretty much see the same spectrum. Also, this issue, like I said before, with service delivery. This is a huge piece of the pie, this bifurcation where there's a struggle. Is the mental health agencies in the state responsible for taking care of, say, someone with Down syndrome who has depression? Or is the pot of money that's set aside for mental retardation, are those individuals, so say the folks at Sierra Regional or at Rural Regional? So to whom does it fall? Also, prevalence rates. The data are all over on prevalence rates for psychopathology in this population. Some say it's hovering around 10%, but other folks argue, and this is more recent, data suggests that it's above 50% of individuals with these types of disabilities have some sort of behavioral or mental health issue. So nailing that down seems to be really important. But what we can say on the bottom line here is that we've got inpatient units inundated. And what I have found is inpatient units are often inundated with young men, I would say ages 18 to 30, with borderline intellectual functioning, substance abuse, often comorbid with some sort of severe mental illness like psychosis. So that's the type of thing that we're looking at an inpatient level in both in Nevada, here in Alaska, and all over the United States, and I'm guessing worldwide in certain pockets. Also, another major issue I'm sure you're all aware of is caregiver turnover, and this isn't just direct service people, but also in the area of individuals offering any kind of behavioral modification, therapy. There's just a huge turnover rate, but especially in caregiver staff, the people who live in group homes. These folks, I think I remember when I worked there, I'd been there 5.5 years, and there was one individual who'd been there for 3 years, and that was a long time. So again, we've got this tension, these gaps in service delivery, and then this question of prevalence. But what can we distill out of this? Well, we could say, people with cognitive limitations are certainly vulnerable to psychosocial stress. That would be the bare bones way of looking at it. My personal opinion is they're very vulnerable to psychosocial stress, to stigma, to self-judgment, to slipping through the gaps in service delivery. And we can certainly say they're less likely to be accorded psychotherapy, any kind of partial hospitalization or day treatment. These were folks who, boy, they'd be, dumped into the hospital in Fallon for half a day and then dumped back out again, for example. I saw that all the time. And any sort of like inpatient hospitalization, I would get told over and over again that these folks were just, quote, not appropriate for there. And perhaps they weren't. But again, it begs the question, well, if they're not appropriate for there, then whom to serve them? So here's kind of the big picture. We've got on the clinical side for identification and diagnostics, we've got determination of the problem, and what I see as a huge problem is the use of antipsychotics. And I can't say that I'm some world expert in this, but what I have seen in both Nevada and in Arizona, I worked there for 2 years, and now here in Alaska, so across 3 states and across a number of settings, including the VA system, as well as working there for the state of Nevada, working here in the university system with even college students, this problem of antipsychotics given as behavioral modification rather than an antipsychotic. Abilify was a new generation antipsychotic about 5 years ago, and it was being handed out like candy as a behavioral mod rather than to any of my folks with schizophrenia. And it just seemed to be common practice, and I've seen it across 3 states. I don't have enough data to suggest it's everywhere, but there is literature to suggest that neuroleptics, anxiolytics, etc., et al. Are given at a great disadvantage for these individuals. There's this diagnostic overshadowing as well, where an individual comes in, presents for services, folks label the behavior as challenging. Well, if you think about it, pretty much any behavior that shows up, you can label it as challenging, depending on the context. So, I've seen mothers who feel that their children, have challenging behavior, or caregivers, or you name it, the full spectrum of folks dealing with anybody in this type of scenario can find any behavior challenging. And what I've seen more often than I would like is this doling out of drugs, kind of a pills not skills approach. I have seen a bit of provider prejudice. However, it's not as rampant in my personal experience. I have seen individuals be treated quite well, actually, in general, and afforded a level of dignity. And so I think that we can say that at least in the settings that I've had the privilege of working in, I've been lucky to not see a lot of prejudice. However, I think on a meta level in our field, and I'm speaking in our field in terms of clinical psychology, I want to say that the idea of folks in this borderline level of intellectual functioning and et cetera in autism, Asperger's, I think that the prejudice in terms of them not being considered or deemed appropriate for traditional psychotherapy on a more macro level, I think that that is changing. While I have not seen a lot of prejudice one-on-one personally, you read about it in the literature, so I would like to think it's changing. So on the client end of things, the issues with identification and diagnosis, these are the obvious, I guess, the verbal limitations, the lack of insight and perception, and also the verbal repertoire with reporting issues. Also, a somewhat concrete problem solving skill set. So we're looking at a group of individuals who are told to, quote, control themselves a great deal of their day, but not really given a lot of solutions on how to do that, that are positive. PBS, of course, positive behavioral supports, have changed that on some level because of the emphasis on increasing self-sufficiency, determination, least restrictive environment, those types of things, which is an increase on positive learning versus a punitive, hey, if you don't do this, you're going to get something taken away. But I do believe that that has blended into the problem, whereby someone has an issue with, say, they're feeling depressed, not sure they're super comfortable always talking about it because they might be told, well, hey, you better handle that or deal with that, or X or Y is going to be taken away. And I have seen that. I would like to say, let's see, I would say Sierra and Rural were implementing PBS right around the time I was leaving, so that was around 4 or 5 years ago. So I hope that that is kind of changed. And the last thing, what we would expect, this low adaptive behavior skills getting in the way in terms of identification and diagnosis. You've got an individual coming in whose adaptive skills in the area of, say, hygiene, it just might distract you as a clinician. You may think that the individual is functioning at a lower level than they indeed are, but it may be just one pocket of adaptive skills deficit. For example, I had a client there who had Asperger's, who just really hated to clean up. He just did not want to clean up, but his IQ was, it was in the normal range. He just had certain pockets of adaptive behavior skills deficits that made his identification of his issues and the diagnosis of such difficult to get to. So I'm not going to go through all of these, but just an overview of challenges in general. Obviously, individuals may have issues with memory, especially folks with TBI, understanding consequences. This inflexibility and rigidity of repertoire, I'll talk about that quite a bit. Also, just if you're a clinician, creating metaphors and language that actually work in this population. I've been tinkering with the protocol, and I just sent you guys a new copy of it. It's a constant tinkering. Also, just some of these things as a clinician. And in ACT, we wouldn't want to give a bunch of reasons. In fact, we're trying to pull away from reason giving. But you find yourself, and I'm guilty of it too, wanting to give reasons why, in quotes, why you're telling them this, or why you are wanting them to work on something. So there's a pull for reason giving. Also, explaining what is a value. It's hard to explain that to a cognitively normal population. Folks often will stand up in ACT workshops, and those of you who have participated in some of those moments where you ask someone to stand up and be psychologically naked, emotionally vulnerable, and state who you are and what you want to be about and what are your values. You know, I've seen it over and over. People just burst into tears. They're not sure. It's difficult to have insight even in a cognitively normal population. So then in this population, you end up trying to explain, in quotes, what a value is, and it can get tricky. So some of the other things, the pull to explain, and just in general, rigidity is thought to be found statistically higher in folks with PDD and mental retardation, and this shouldn't surprise you guys, being in BA. So the application here, there's some analysis in the literature about developmental stages, and we can talk about that too, because it has some link to how our interventions developed. Are individuals with retardation subject to the same developmental processes as others, or are they not? And then there's a camp that says, sure, they go through the same developmental stages, and then there's a camp that says, no, they do not, that there are cognitive cliffs, and that they do not. And so I think wherever you fall on one side or the other of that argument, or in the middle, wherever you might be, depends on what type of treatment intervention you think might be appropriate in terms of development. Also, these are individuals who I believe they have the same obstacles and response repertoire issues that the rest of us do. I do believe that they may not develop the kind of range of responses or the abstract abilities to discriminate contextual clues. What I mean by that more specifically is that ability for perspective taking, the ability to put yourself in someone else's point of view, and or read your environment to know whether you are not making an appropriate social move or not. These are some folks who are kind of impervious to that type of feedback. Either you're giving it to them, or they are maybe impervious to reading it. And this is just a generalization. Not everybody in these categories meet these criteria, but they're just things that you have to think about when you're looking at the overall application. So I'm not going to go deeply into RFT because I'm talking to a group of folks who know about RFT, but we know that looking at this issue through an RFT lens suggests these types of inflexible responses may give rise to these psychopathological processes that end up in behavioral health and mental illness issues. So the whole idea here was, of course, a treatment technology like ACT that targets development of flexibility in the face of such rigidity and these derived stimulus relations that are extremely difficult to break up and are maintained, as you know, by sense making and order, especially in this type of population, that maybe ACT might target that and offer assistance. So we were challenged when Steve and I first started talking about this. Some folks said, well, you know, ACT is too verbal and too cognitive. But we kind of felt like ACT might make sense. I mean, these folks, the same destructive verbal processes as the rest of us, and the same acceptance and flexibility obstacles as the rest of us. So we felt like maybe these inherent ACT principles, and you probably noticed from my protocol, I do a FAP enhanced ACT. I don't call it FACT because it's not fact. It's sort of my FAP and it's Julieann's FAP enhanced ACT. But I really think that the pieces on consistency and predictability, equaling trust that you pull out of FAP, and the rapport building in terms of the ACT stuff and the non-judgmental stance of ACT just sets the stage for being able to intervene with your hexaflex model, etc. And you know, you are aware there's this growing body of evidence to suggest that ACT reaches a broad range of problems and touches a range of severity, from psychosis to interventions for folks in the more ordinary range. So the intervention I developed is a combination of metaphors, experiential exercises, concrete language, and kind of this repetition and contrast. Was developed from the principles underlying ACT. I did try, I noticed in some of your questions, one of the questions was good. Do I think that why protocols haven't been written at this kind of a level? I don't know how to answer that, except I'm not sure that the larger therapy community thinks about these issues in the same way we do coming out of Reno. I mean, I guess that's kind of the best way I could answer that. I think that we're set up uniquely coming out of there to think about this in a unique way. And that's what was driving me to kind of come up with really what I'd call physicalized metaphors, things that they could draw, they could act out. I have them stand and move. We draw on the board. We jump up and down. I have them with real world things, and it seems to encourage understanding. And I see no reason to think that that wouldn't work in cognitively and physically abled individuals, and it seems to. I've mapped some of them also with kids. I worked in Reno for a summer working with kids, folks who were on the Medicaid waiver there in town, and I did my ACT protocol with them, and they loved it. They loved all the drawings and the jumping around and the dancing. I had them singing, dancing, drawing, and it seemed to, I don't know, it avoids this kind of need for abstract modifiers and complexity. And there was a lot of repetition, and there were a lot of real specifics. I didn't get general. I think that one thing is important working in this population. You want to focus on measurable outcomes, real specifics. It might be just that your client, for example, has one repertoire issue or one behavioral issue that is causing accounting for about 80% of the variance of their issues. And so I think that focusing on in these specifics, very important. So I created some exercises, and if you're interested, you could look through the protocol. So just briefly, I know you read, or I sent you the pilot study. I did just a little single case study. I was interested in one of my clients. She was a 22-year-old Hispanic female presenting with undifferentiated psychosis, although they just wrote schizophrenia on her chart, but on digging I found that it was undifferentiated psychosis. She'd been she'd been in a foster family since she was 2. She had been removed from her home due to abuse and neglect, and she was an interesting individual. She had one strong hallucination, and that was a voice telling her to kill herself. And she had 2 very strong delusions, and one was that she had a family. And this makes sense, I guess, from a Freudian standpoint, that she felt that she had a family. And when I first met her, she told me all about her mom, her dad, her sisters, and her brothers. And so she had a strong delusion that she had a natural biological family living in Reno, that she did not. And she also had delusions about medical issues. And at some point in her childhood, she'd received some attention for some problems with her legs, perhaps, I think it was scoliosis. And so her spine was a little curved, so she had gotten braces on her legs. Well, she was, at this point, when I met her when she was 22, still insisting she needed the leg braces and she wanted a wheelchair. And another real important piece, too, was that she liked baby things. She carried, because of this family, she not only thought she had a family, she also wanted to have a baby very badly. And so whenever she had spending money, she would want to go spend it on baby bottles, baby blankets, etc. So we wanted to focus on some outcome measures. She wasn't compliant with her meds per se. She barely ate, citing that she was depressed over her family issues. And she would take apart her appliances in her apartment at night when her caregiver was asleep. She would get up, and she had a particular interest in her dishwasher. She would get up in the night and dismantle it, take it completely apart. Also, she had issues sleeping in her bed. She didn't want to sleep in her bed, so she'd sleep on the floor. Interestingly, in what we did, I did just a little 4-session ACT intervention that's described in that paper that I sent you guys. And success was demonstrated on all outcome measures. I was really excited about it. By session 3, she was no longer taking away her appliances. She was sleeping through the night in her bed. Her eating went into the normal range. And I'm just going to say there as a little asterisk, this was eating as required by staff. So this was sort of mediated by them. They had, based on the food pyramid, stuff that they wanted her to be eating. So this was it was in the normal range as measured by staff, and her med compliance was reached by the 4th session. So after we did the little single case study, I became interested in developing this out for my dissertation. And I saw that one of the other questions was from Tom, saying that, you know, we kind of jumped quickly from single case to a little controlled, a random, an RCT. And yeah, we did. Obviously, I was trying to do something cool for my dissertation, but the N was very small. But I do agree, Tom, that it would be, there's no argument for me. I do think it would be beneficial to generate and get more of a buy-in from the behavioral community in terms of bridging the gap between the clinical world and folks who more generally work with the DD population to do more single small N research, single case designs. I would love to see that, and I'm working on that in my lab right now. So I'm pretty excited about that, and I'd be glad to talk about that later. So anyway, just a few slides on my dissertation briefly. I had, just like I said, a small N. It was a total N of 23. I had 4 groups. There were 2 groups of 6 in the ACT group. In the treatment as usual, 1 group of 5, 1 of 6. 2 groups received the treatment intervention, 2 groups received treatment as usual, as expected, not split by age, gender, or race. And then I did a pre-treatment interview, which was this evaluation for determining the understanding of informed consent. So just a quick word on this, and Steve probably remembers this. We went through quite a bit with the IRB at Reno. It took me 2.5 years to get through IRB there. It was a very long process for me, and I wrote 13 drafts to the IRB over 2.5 years. And at some point, I got pretty cranky about it, but I did get it through. But they were, you know, and I understand their concerns. They were concerned about whether the individuals could give informed consent. And really the feedback I received from them was individuals with, well, let me back up just briefly. Individuals with retardation, as you probably know, are stratified between mild and moderate and severe and profound. Okay, and then there's borderline intellectual functioning, which is above an IQ of 70. Well, the IRB felt really strongly that if I wanted to do an intervention with the severe and profound, that I could do that, because those are individuals who are more likely to have people who could sign for them and give informed consent. The people with severe and profound disabilities are more likely to have either a public guardian or a caregiver or someone who could give informed consent. Folks with moderate and mild retardation, at least in the state of Nevada, often sign their own forms for rural regional and Sierra regional, and as such have had a long history of signing those forms. But the IRB felt strongly that, boy, we could do whatever we wanted with the ones who could have someone sign for them, but it was kind of like they were saying that the individuals with mental retard, they were not handicapped enough to have someone who was their signatory, so we couldn't work with them. But the ones who were more handicapped, who had a signatory, I could work with them. Well, as you know, therapy is verbally mediated, and to work with someone in the severe and profound range would be quite difficult with a verbally mediated therapy. So it left us in this gray area, which we struggled through. But in order to get around that, I did 2 things. First, I did I came up with, and I can send this to you guys too. It's not in anything I sent, but it's in my dissertation. I called it Fun Questions, and basically this pre-treatment interview was, I was trying to understand if they even understood the idea of a Likert scale. And the fun questions were things like, how often do cats fly in the sky? How often do people wear clothes to church? How often do people walk to the store? How often do you see a green-colored dog? How often do you eat milk with a fork? How often do you breathe air, etc.? And it was on a scale, and I was interested. I wanted, because research indicates that adults with disabilities, if they're screened for adequate receptive vocabulary, and they're found to be capable of reporting on subjective feelings, then that is going to, of course, increase the validity of what you're looking at. So there was a pretty heavy nature, high volume of self-report items in this study, and I was worried about the potential perception and cognition barriers. So I kind of wanted to ascertain their abilities around understanding the nature of a Likert scale. So that's why I did that. That was the pre-treatment interview, and that screened folks out. And there was, I had like a scaling and scores of 8 or higher. They were considered sufficient to enter the study. And then after that, I put them through an evaluation for determination of understanding of informed consent. I wrote that for the IRB, and that also had questions like, for example, what am I asking you to participate in? Is this project something you have to do? What does it mean when someone is confidential? How can you stop from doing this? What does it mean to sign your name for consent? And do you understand that your services here at this place will not be changed if you choose to do the study or not choose? So anyway, just a quick blurb on that. I was trying very hard to get around any kind of possible criticisms, down the road in terms of the cognitive limitations. So just briefly, in my DISS, my primary and secondary outcome, my primary and secondary process, my outcome measures was an adaptive scale, and the ADAMS, which is a measure of psychopathology. Some secondary ones, an anxiety and a depression scale that are normed on people with disabilities, and so have words written that are more easy to understand, and a life scale that I developed myself that just asks basic questions about functioning. The AFQY, which was our measure of acceptance and flexibility. I modified the bullseye. I can't remember right now who, you'll have to remind me, Steve, who initially did the bullseye, but I modified our ACT bullseye, and just basically it was a huge bullseye, like a target that you would throw darts in, and it was the closer you got to the middle, that was of greater importance. And I did one for, are values important for you, and are you going in your valued life direction? And again, I'd be glad to share some of this later, but and the process measures, a lot of ACT studies include the ATQ, and we've kind of modified them over the years. We're looking at the frequency of thoughts and the believability. So all in all, there wasn't a ton of measures, but this was my basic ones. And my basic hypotheses, I was hoping to see lower levels of psychopathology and higher levels of adaptive functioning. I was hoping to see lower levels of depression, anxiety, higher levels of coping, lower levels of inflexibility. I was hoping to see an importance in values and attempts to live in a valued life direction, and I was interested to see whether they would report frequency, lower frequency and believability. And there was no significant differences in our initial baseline analyses in demographics or any of the variables, and we just did your basic straight up analyses. We did some repeated measures and COVAs as our primary analyses, and then Steve led me through understanding how to do these bootstrap non-parametric cross products to look at mediation. So I was pretty excited I guess that's an understatement. We found some significant and large impacts in the ACT condition in our measure of psychopathology, and significant and medium with our adaptive functioning. We had some phase effects across the 3 phases. In our depression scale, significant and large reduction in reports of depression. Interestingly, in the Glasgow, reduction in reports of anxiety with a phase effect at session 3 post and follow-up, and this is when I really hit anxiety in the protocol that I was using, so that was pretty cool to see that worked as I go back, as I click myself. The AFQ, we had some significant and large differences in reports of flexibility, And there was a phase by condition interaction effect again by session 3. It seems like by session 3, stuff was really clicking. And it just anecdotally, what I'll say there is that session 3, for some reason, just seemed to be fairly magic in both of my ACT groups, and so I'm not sure what's accounting for that. But I definitely took that into account when I redid this new protocol that I'm working on now. I'm not sure why session 3 seemed to be the magic session where things started clicking, but I reformulated based on that. My valued life direction, we had significant and large differences there. So folks were actually, by post and follow-up, it seemed to be settling in that they wanted to have some changes in their life direction, and it was important to them. There were some significant and large differences in frequency and believability of thoughts. There was a phase by condition on a frequency of thoughts in the ACT group, again in sessions 2 and 3. And again by session 3 in believability. And these were maintained at post and follow-up. And our mediation, our AFQY scores were significantly mediated in the follow-up on adaptive behavior and psychopath. So it was pretty cool. So overall, just the results, it looks like that my kind of brief little ACT group improved functioning. It reduced the measure of psychopath, increased flexibility, and increased time spent focused on importance of values and living in line with one's values. It did assist clients with increasing psychological flexibility and the importance and incorporation of values, reduced both the frequency and impact of negative thinking. This kind of suggests to me that the ACT intervention altered processes of cognition and possibly metacognition. And our mediation, which was the ultra cool part, supported the importance of ACT processes. So our post-change scores mediated both the follow-up changes in adaptive functioning on our Vineland and in psychopath on the Adams. So it was a lot of, how do I, even like talking about it now, I think I have a little PTSD about it. But I mean, we went through 2.5 years to actually be able to do this, and I was very excited. I'm still excited to talk about it. I do want to mention briefly some limitations to this research, because I think it has merit in terms of discussing limitations in general for any of us who are interested in working with this spectrum. The change scores for my folks in this study were within a range still of clinical distress. They moved, but they were still on some of the measures within a clinically distressed range. So even though, say, there was a reduction in the measure of anxiety, they were still highly anxious folks. So I think that's of merit. There was no ability for me to do a long-term follow-up because I was up and out of there to head on out to my internship. And I think that in general, that's a problem in doing any of the research that I've read. There's very little follow-up. And I know that there's a lack of follow-up in a lot of research in our field, but I'm just saying in particular with folks in this spectrum. I did lack an active control condition. Treatment as usual was basically just seeing your case coordinator for your normal time that they would see them weekly. So there was not an active control. There is a social desirability effect in this study. These folks knew me, and I think it was in play, wanted to do well for themselves and for the caregivers. And so I think, you don't want to underestimate that. I don't want to downplay the results because I think they're real and they're there, but I think it's important to mention that. Obviously, there's a small number of participants. There were a lot of analogous baseline scores. A lot of people were kind of in the same range in the beginning. And there was a new protocol. I'm still, as of now, I'm finally pretty happy with this thing, but I've been tinkering with versions of this protocol. I think I'm on the 6th or the 7th year of it. So I'm finally at a place where I feel pretty comfortable with it. So just kind of summing up in a discussion kind of a way. So our conceptual framework, They've traditionally received little or no psychotherapy. Mental health is often subsumed under mental retardation, and so these folks are the ones that have to, quote, intervene, and maybe they're less trained than folks over here in terms of ways that would help and on a more on a traditional psychotherapy kind of a way. Also, there's more money over here in this pot. And if we bump them over to mental health, they have less money and they're already inundated, especially in Nevada, like with Nevada being such a high suicide rate, et cetera. There are other issues that this group of folks are interested in the state of Nevada. And in this state, to be frank, we're interested a lot in Native American or Native Alaskan health issues. So it's not on the top of the mental health pot of money to deal with, so it gets booted over here. How does ACT fit in here? I think the entire distribution of folks that I've seen on this spectrum does appear to suffer equally from these verbal entanglements we talk about. The social verbal community is alive and at play with them as well. Therefore, they're subject to the same contextual variables as the rest of us. And they're, and the bottom line here, they're individuals at risk. They have interpersonal deficits. They are at risk for prejudicial treatment and societal stigma. And there's traditionally a lack of coping mechanisms, and that's translated into what is termed in the DD field as, quote, challenging behaviors. And I think it's kind of hard for folks to pretty much do anything and not have it termed challenging in some way, even if it's something where they're just asserting their rights on saying, well, gosh, I would like more of my money this week to go buy something. Then they get slapped with the label, well, they're challenging. So I think that's kind of an issue. So, the goals of my research are what I care about. I think there's a lot of relevance for inpatient scenarios. I've just been on too many inpatient units where they're overwhelmed and don't know what to do with individuals with this type of spectrum. Caregivers and direct service staff are often underpaid and undereducated to handle this stuff and overwhelmed, which leads to turnover and burnout. And I do think there's relevance for traditional practitioners. We can weigh in on this and have something to say that's meaningful and helpful. I think that anybody working in this area, again, this is my personal thing on this. I really want to focus on a least restrictive environment and issues like dignity, self-sufficiency, autonomy, functioning across the domains of the person's adaptive functioning and overall quality of life. I'm interested in person-oriented rather than disease-oriented to increase quality of life, natural supports. There's a couple stories I could talk about there's kind of this inherent, I think, I don't want to say stigma, but there's this inherent, entrenched maybe viewpoint that the increasing of natural supports is not necessarily a good thing. At least this has been my perspective, that the caregivers maybe have a different idea. There's a lack of boundary issues, maybe I'll put it that way. So there's quite a bit I could talk about on there. I kind of think just the overall reduction in symptoms, reducing staff stress and caregiver burden, and improving quality of life. These are all things that are fundamental to our field in general, and in particular to this group for me. And lastly, just the meta-level benefits. I saw, a lot of behavioral problems were attributed to their medical diagnosis of retardation. I saw a lot of ignoring of issues. I saw the high costs and economic burden. I witnessed a ton of things, over-medication, just caregiver stress, the possibilities of stigma. And I do think that there's application outside of the state of Nevada and where I was working at the Rural Regional Center. So future directions. This sort of the end here. Despite any limitations I kind of talked about above, I think my initial research offers support for the significance of ACT processes and methodologies with relationship to this population. I think they are sometimes swept under the carpet and sometimes over-medicated or improperly medicated, maybe not over as much as improperly. I think any of us who are interested in doing this, it's an important step. I think my protocol, it's always going to benefit from expanding in length and breadth and width and anything. I'm always going to be working to try to make those metaphors more concrete and work for this population. I do think that anybody who shoots off in this area is doing something innovative and noteworthy. This work that I've tried to begin, it does target and impact our idea of the theoretical mechanism of change specific to ACT and ACT processes. And I do think the significant results indicate ACT's potential effectiveness with regard to quality of life, improving psychological functioning, self-sufficiency, self-determination, also on measurable outcomes, specific ones, like helping them with medication compliance, helping them, the spectrum from that all the way to being less depressed if you're getting into the mental health issue. So overall, my sense is it was just best not to kind of, I didn't want to focus on any limitations these individuals presented with, and I was very interested in focusing on achievements and positive growth. And I think that the ACT model worked well to blend with that. And that's all I got to say about that. I can't see it. Thank you. Thanks. Sure. Or I'd be glad to expand. Yeah. Hi. Well, let me see. Well, you had good questions. Yes. Nice. Sure. Yes. Mhm. Absolutely. Right. Yeah, let me see what I wrote down here. That's how I was going to answer your question. I think, um, yeah, and you know when I ran into that, you probably know down in Carson City there are a number of I guess they're contracted with Medicaid service providers like Educare. I don't know, are they still in business, et cetera? Those type, yeah, as you they're not okay, and I'm not surprised. What I feel in terms of sustainability is that caregivers are integral to this. And so with that in mind, after I did that initial single case study with that client with schizophrenia or undifferentiated psychosis, but they insisted on saying, well, she just has schizophrenia, whatever. Anyway, I wrote a little 2-page brief intervention plan, and I went and role played it with them, and the actual caregivers were very excited about it. They said, oh wow, this is going to be really helpful. And I said, well, the idea is that I've only been here for a short amount of time, and I want this to generalize out to other behaviors in her repertoire and in her social world, and I need you guys to help maintain it, like a wraparound. I explained the whole idea of wraparound services, etc. And they got it, and they really, but what happened is it wasn't maintained on an administrative level. So where the individuals on the ground were extremely interested in it and got it. I mean, they really understood what was going on. In particular, they were working with her, so they saw the change and were excited, but they found that they were not, how do I say this? They just weren't, from an administrative level, it was not maintained for them. So I think that part of the onus is on us to not just, as you know, you're right. You know, we can't just fly in, intervene, and leave. I've done a lot of cross-cultural research, and that was one of the major issues when I presented to the Navajo and Hopi tribe to do my master's thesis. And they said, you know, are you just going to be one of these people who comes in and does your thing, does a write-up about us and says, oh, there's the American natives doing their thing again? And I said, no, I really want to create a plan for you. So I created a plan that they could then take in their schools to address some of the healthy and unhealthy behaviors their youth were engaging in. But I think follow-up is not only, what I'm trying to say is that follow-up is not just about one-on-one with the client. It's about these wraparounds and in the community and educating everybody involved. Because with these folks, it is not just that you're the individual serving them. There's a treatment team. There's care providers, there's the psychiatric nurses, there's a psychiatrist who they see like once every 3 months, et cetera, et cetera. And that's just how it is in Nevada, and it's different in Arizona and different here, but it's pretty much the same. And so everybody's kind of got to be on the same page, but if everybody's not doing the same thing, then it just falls apart. So I think, you know, your comments were, and I wrote on yours, I wrote, you've got no argument from me. The only other comment I had was, you know, IRB is an issue, not because IRB is a problem. You know, obviously I believe in the philosophy of IRB. I just mean that we might also, in order to be able to offer more research and more interventions, spend more time as a group of individuals who are interested in this, talking about ways that we can discuss it and use language that doesn't alarm the IRB. Because that's what happened. I mean, I would write things that, and I kind of talk about it, and I can say this to you guys because, you know, I mean, we have like Reno speak. We all know what the rest of us are saying, but other people sometimes don't. And I mean, Reno speak in our department, in the psych and the BA department, and so we know what we're saying. But I'm running through it in my lab right now because I'm having my lab read various articles that have been written by folks out of the lab, and they're going through it and they're like, well, what is this? And I'm like, oh, that's Reno speak, okay? What we're trying to say is this. So we might benefit from that as well. So that was my other thought. Finding language that's user-friendly for individuals outside our little contextual bubble of Reno at our department. Absolutely. Yeah, it's fun. I agree. Hi, Greg. Sure. Um, let me start by saying yes. Did you ask this question on a piece of paper or did someone else ask it? No? Okay. Okay. Um, the reason why I'm asking is I'm hoping to cover both grounds on both questions, but yes, and I get asked this quite a bit. So, our, uh, here's what I think about it. Okay. Um, we've we've been solidifying what is quote I mean, like, I remember the day the hexaflex was born. I remember the day it went up on the slides on the lab, and we were like, whoa, hexaflex. And it made a lot of sense, but along the way we were grappling with how to present ACT in a way and to various populations if it was a first foot forward, et cetera. And this is when, Kelly and Lab started talking about maybe some clients' values ends up going in the front end of the protocol, whereas before it was kind of this creative hopelessness stuff. And with this population, I have found that the most difficult things to discuss are the self as context and values. And this probably doesn't, stun you. These are the most difficult pieces. One of the questions I was asked is, if you had just uh, one session that you could do, name that tune in one session. What are the core pieces of ACT? And I wrote down quickly because I wanted to answer for myself, like what. Um, I really, really feel strongly that the diffusion stuff and the understanding how these thoughts and behaviors function on themselves and others, so it's sort of a FAP enhanced diffusion / willingness session. That would be what I do, and that's what I do. When I have individuals come in, like say in this college setting right now, who present with autism or Asperger's, that's where I go right off the bat. What thoughts are they fused with? Are they willing to be in the room with them? And I don't lead. It's kind of like a dance. What are you going to lead first with? And that's what I would lead first with. The self as context stuff is difficult for even us cognitively normal folks to I've had to come up with some ways to explain it. Yes. Yeah, I do, because with psychotic folks, let's see, you had said, yeah, because these are individuals who have, odd cognitions, frequent and bizarre symptoms, etc. You said, is there any particular component? And I wrote yes and underlined it twice, because I don't, that, that struggle, the relationship that the individual has with the thoughts. Like, here's the psychotic odd cognition, and right now they have this kind of a relationship, back and forth. And really, traditional CBT is teaching them to try to change this, right? But when we're talking about the relationship between, and we're talking about the function, not the form or the frequency. So what I'm working on is changing the perspective, the relationship with the thought, not trying to change, modify, eliminate, or control it. So you'd want to go there as fast as you can in that population. Yeah, because that's what they're dealing with. And what have they been told and punished by socially their whole life since they got this diagnosis? Well, that's wrong. You're not thinking right. This is an odd cognition. You're crazy. The social punishment, all of that, the pejorative language that they're subject to, etc. So you'd want to go there quick to talk about, I think you kind of have this relationship with your thoughts. It's like, and doesn't that kind of suck? And